Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services for the 82nd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang, Senator Nguyen, Senator Stone, Senator Titus, Chair Donate.
And I am here. Thank you so much. Everyone is present. Good afternoon, everyone. Today we will have a few bill hearings, which I hope would go fairly smooth. Goal is to finish before 4:30. We'll see how far we go. We do have 4 bills. We have AB 40, AB 100, AB 116, and AB 267. Goal right now is to go AB 40, AB 267, 100, and then 116. So we'll get it all done hopefully within the hour. Before I start, I would like to make a few housekeeping announcements. As I mentioned, agenda items may be taken in a different order than listed. For the sake of time today, we will go ahead and limit testimony for each bill presentation to 10 minutes, and then we will proceed with testimony. If you wish to testify, you can sign in at the table at the front so that we can have a record of who you are, and then we may request testifiers to submit additional documentation supporting their testimony. And anyone that wishes to receive copies of the committee's exhibits can go to the Nevada Legislature's websites, and you may also request copies from our committee manager. We're going to go ahead and start with Assembly Bill 40. This bill revises provisions related to inspections of food establishments. Ms. Finney, please begin when you're ready.
Good afternoon, Senators and members of the committee. For the record, I am Teresa Hayes, and I serve as the Environmental Health Program Manager for the Nevada Division of Public and Behavioral Health, the agency charged with implementing changes to NRS 446. With me today is Coney Finney, who serves as the Administrator of the Division of Public and Behavioral Health. Today, I would like to provide you with a short description of AB 40 relating to food establishments requiring an applicant for a permit to operate a food establishment to provide an electronic email address for purposes of communicating certain notices, and allows us to provide some of our notices in an electronic format rather than a hard copy. Our purpose is to be responsive to business. Paper-based inspections may result in delays in getting the inspection information to the operator, who can promptly make necessary changes. Paper forms may be lost or damaged, leading to delays in the resolution of observed hazards. Also, corporate headquarters may be located in another state or country. The requested change will not prohibit us from providing a printed copy to the operator upon request. Official documents regarding enforcement actions such as suspension of a permit will still be submitted on paper and delivered personally to the permit holder or the person in charge, or sent by registered or certified mail. EHS has had multiple requests from industry leaders to institute this change. Digital inspection reports allow field inspectors to upload their inspection report so that the operator gets the findings the same day the inspection took place. More immediate inspection results in faster identification and attention to the deficiencies, which improves response times. In addition, an electronic submission provides a digital trail that provides owners and managers to be sure that they were notified of existing problems. The Division of Public and Behavioral Health was submitted to the bill sponsor a friendly amendment to correct an error that was missed during the review process. The amendment changes must to an email addressed to may, knowing the electronic communication is not the preferred method for many of our rural permittees. Thank you for the opportunity to be here today, and I look forward to answering any questions you may have.
Thank you so much. Committee members, any questions? Senator Stone.
Thank you for the presentation. Seems like a pretty simplistic bill. Does this apply also to food trucks?
For the record, Teresa Hayes, Environmental Health Program Manager, through Senator Donate to you, Senator Stone. Yes, they are food establishments.
Thank you so much. Any other further questions? Seeing none, we'll go ahead and move on to testimony and support. If you are in support of Assembly Bill 40, please make your way to the front. Is there anyone here in Carson City? Anyone in Las Vegas? And BPS, anyone virtually?
If you would like to testify in support of AB 40, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Let's move on to opposition. Is there anyone in opposition in Carson City, Las Vegas, and virtually?
If you would like to testify in opposition to AB 40, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And last but not least, anyone willing to testify in neutral on this bill? Anyone in Las Vegas and anyone virtually?
If you would like to provide testimony in neutral for AB 40, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Unless there's any closing comments, we'll go ahead and no. Okay. We'll go ahead and close the hearing on AB 40 and move on to AB 267. This bill revises provisions governing cultural competency training. With us, we have Assemblywoman Torres. Welcome to Senate HHS, and please begin when you're ready.
Thank you. Perfect. And I do have a couple guests. I think one more is probably hopping on, and if she doesn't make it for the Assemblywoman Torres, for the record, if she doesn't make it for the presentation, we could just have her add her comments to support. Good afternoon, Chair Doñate and members of the committee. For the record, I am Assemblywoman Selena Torres, and I proudly represent Assembly District 3 in the heart of Las Vegas, Nevada. And thank you for allowing me to present AB 267 for your consideration. This measure establishes and increases training requirements for cultural competency and diversity, equity, inclusion for certain employees of medical facilities and healthcare professionals. Just some background information. As many of you know, cultural competency training focuses on skills and knowledge that value diversity, understand and respond to cultural differences, and increase awareness for providers and healthcare organizations and cultural norms. We know that effective health communication is as important to healthcare as clinical skills. There is strong evidence that cultural competence training for healthcare and mental health professionals improves providers' knowledge, understanding, and skills for treating patients from culturally, linguistic, and socioeconomically diverse background. To effectively serve diverse communities in Nevada, such as the API community, Latinos, Native Americans, and many more, we need healthcare practitioners who understand, respect, and value all of the cultural differences and perspectives within our community. Based on this background, I'm bringing forward AB 267, which requires certain healthcare facilities and professionals to complete cultural competency training. The objective is not only to provide the overall patient experience, but also to reduce the potential for miscommunication and misunderstanding because of cultural differences that could lead to adverse outcomes. This bill reflects our state's commitment to fostering an inclusive healthcare environment that caters to the unique needs for every patient, regardless of their background. Quite honestly, this is a bill that I worked on pretty significantly in First House and was amended pretty significantly in First House to make sure that we were adopting changes that made sense for hospitals, made sense for clinics, and made sense for hardworking Nevada families. And I think that that's exactly what this bill does. I think the bill in front of you today, the reprint, is representative of a compromise and of a negotiation, and representative of what Nevadans need. At this time, I would like to go ahead and defer to Dr. Lauren Chapo-Love, who will talk more about cultural competency training.
Thank you. My name is Dr. Lauren Chapo-Love, for the record. I'm a licensed psychologist providing mental health services in a private practice in Las Vegas, Nevada. Cultural competency is viewed as the building of knowledge and skills relating to groups, both similar and dissimilar to our own. It's important to recognize that these groups are not solely based upon the diversity that we can see. So this bill also addresses populations like youth, elderly populations, veterans, and a host of other populations that I think really represent Nevadans today. So given Nevada's growing diverse population across all of these different spectrums, and oftentimes across multiple spectrums for one person, the medical and mental health providers who serve these communities, we've already started to establish that we have an ethical as well as a professional requirement to improve our skills to be able to work with these populations that we serve. Through recognition that many individuals live within complex constellations of intersectional identities, the continuing education component of our training has to also reflect the dedication to providing more equitable care to those same communities, oftentimes the same communities that we live within as well. Regarding the discussion of the use of the term cultural competency, I feel like we oftentimes get pretty jammed up here, right? So one may see this term as more of an inclusive umbrella. This is covering a network of educational tools, perspectives, evidence-based practices, and client and or patient-centered skills. So how do I work with this particular population? The concepts of cultural humility and cultural responsiveness also give way to the notion that me considering myself to be competent, if you will, in the finite sense, is not a research-based view. It is not a possibility that is realistic. Rather, we professionals are tasked with continuing to build and improve our understanding of these competencies as they grow and as we too grow, in much the same manner that we continue to build upon other clinical skills that we need for our respective jobs. Similarly, experiences or exposure to a particular population is not sufficient to suggest that a person has met a level of cultural humility with that population. I, for example, will not propose that I'm competent simply because I identify with a population or know someone else that does. We also want to recognize that historically, many of our field have fallen far short of inclusive or equitable care, and at times they've caused harm. We have caused harm or increased healthcare disparities, which does the same thing. With apologies and acknowledgments pouring in from a host of provider associations, the American Psychological Association, the American Medical Association, the National Association of Social Workers, the list goes on. The below quote is a summative explanation of the current shift in many of our fields relating to cultural humility. This, of course, comes from a 2009 case for cultural competency in psychotherapeutic interventions paper. So Ridley in 1985 has argued that cultural competence is an ethical obligation that cross-cultural skills should be placed on a level of parity with other specialized therapeutic skills. As an alternative to the passive do no harm approach in ethical standards in many helping professions, Hall et al. In 2003 advocated that ethical standards mandate cultural competence via collaboration with and sometimes deference to ethical minorities as well as communities and experts. In short, we now see that training within cultural competencies being mandated across a host of educational curriculum before a person even gets to practice. We would like to continue that. So I want to note that not only the need for increased training, but also the development of effective training opportunities. This is contemporary research talking about or having begun efforts to focus upon identifying methods to implement evidence-based strategies towards more efficacious cultural competency training. More notably, preparing for the training by knowing your audience, developing a succinct and accessible training curriculum, employing the most effective methods of presentation delivery, choosing effective and well-informed trainers, as well as providing opportunities to have the participants offer evaluative feedback about the training. So this is how did the trainer do as well. This is one of the ways that a paper that I've included for the committee's reflection, a 2022 paper on developing standards for cultural competency training for healthcare providers. This is one of the ways that this is going to help improve not only the training that we get, but also the quality of care that we're being able to provide Nevadans. I would like to thank the chair and the committee for your time and consideration.
Thank you. And I believe that Dr. Sandra Leon just got on. So when you're ready, please begin.
Hi, good afternoon. As Assemblywoman Selena Torres mentioned, my name is Dr. Sandra Leon Villa, and I'd like to thank the chair and the committee for their time and in advance for their consideration of this bill. I'm a licensed psychologist in Las Vegas, Nevada, and I've been in the mental health field for about 15 years now. And although Nevada is said to be a majority white state with approximately 50.3% of the state identifying as white, it must be noted that nearly 50% of the state is made up of Black, Indigenous, and other people of color or BIPOC folks. That is nearly 30% are Hispanic or Latinx, 9% are Black, 10% Asian or Pacific Islander, and 1% identify as Native American or Alaskan Native, according to the Department of Health and and Human Services. According to the 2021 Minority Health Report, health disparities continue to predominantly negatively impact the global majority, that is BIPOC communities, in all aspects of health, including mental health and physical health. These disparities include BIPOC communities. It includes Black individuals having the highest mortality rates across various health conditions. Mental health is the poorest among Black individuals, and we have the highest depression rates among Native American individuals. And Latinx or Hispanic populations continue to be the largest affected by COVID-19. In fact, Nevada is ranked 35th in the country for health equity when it comes to minority or global majority health. This is concerning when we pair this with low levels of education and income, which make up the vast majority of our population with most households. For example, Latinx families, the largest global majority population in Nevada, report that approximately 39% have a level of education lower than a high school diploma, while only 8% are college graduates. And this is undoubtedly influenced and exacerbated by low socioeconomic status, with more than 26% of the population reporting an annual income between $15,000 to $24,000 or under $25,000. Similarly, 32% of Black families, individuals have a high school diploma, while approximately 41% have some college, and more than 40% of all Black families and individuals in Nevada report making less than $50,000 per year. And this is important because educational level and socioeconomic status influences access to services and are important factors that contribute to health literacy or the lack of health literacy. These numbers have some significant implications for health disparities and health literacy. According to the CDC, who updated their definition of health literacy in August 2020, health literacy includes both personal and organizational health literacy. And when we talk about personal health literacy, this is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves or others. With regard to organizational health literacy, this is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions or actions for themselves or others. The CDC emphasizes the importance of one's ability to use health information, but also that organizations have an obligation to address health literacy, thus placing the responsibility on health providers. However, in order to understand and address health literacy, it's important to also understand social cultural factors that influence this. Currently, health providers in Nevada, whether physicians, psychologists, or any field that we're really talking about within health, are predominantly white. And this is important to note, given that research, treatment, and interventions have historically been based on the perspectives of members of the global minority, which consequently impacts and contributes to health disparities, as evidenced by multiple National Association apologies regarding harms by various health fields, including the American Medical Association, the American Psychiatric and American Psychological Association, who have all issued apologies for the harms against BIPOC communities. So the current policy that's currently requiring 2 continuing education hours is not sufficient to make a significant impact on these statistics. Specifically, psychologists, for example, we're required to obtain 2 hours of training under diversity and cultural competence every 2 years for license renewal. This equates 1 hour per year of training on cultural factors. And research indicates that the lack of cultural responsiveness is going to result in lack of sensitivity to cultural differences and symptom presentation. And consequently, these leaves providers vulnerable to their own implicit biases, stereotypes, and other negative attitudes that they may have towards certain populations due to lack of training and culturally responsive assessment and diagnosis. So increasing this continuing education requirements will contribute to decreasing the health disparities, because it is implicit bias by providers which contribute to these disparities, and making diversity, equity, and inclusion training is imperative for disparities if we're going to put a dent in this and really have a positive outcome for BIPOC communities. Thank you again for your
Thank you. As someone notorious for the record, and at the chair's discretion, I can walk through the different parts of the bill, but I'm happy to just go right into questions.
I think we're good to go to questions. Committee members, questions. Senator Stone? And then Senator Titus.
Yeah, thank you very much for your presentation, Assemblywoman. I'm looking in section 3 through 9. I see that if you're a nurse, you're to complete at least 4 hours of instruction. If you're a social worker, 6 hours of instruction. Alcohol, drug counselor, gambling counselor, 3 hours. Behavioral analyst, 6 hours. Number one, is that per year, or is that for, usually these licenses are for 2 years? And why the different number of hours based on the different medical specialties?
Thank you, Assemblywoman Torres, for the record. And so I'll talk a little bit about the history of the bill then to help answer that question. So back in 2021, we brought forward this piece of legislation, making it for 2 cultural competency hours. And that's when licensing boards started making sure that this was the requirement. Obviously, with the presentation from my colleagues, Dr. Leon Villa and Dr. Chapel Love, as I mentioned, really that's 1 hour a year, right? Which was insignificant considering the amount of hours that were required biannually. So it was 2 hours every 2 years, so 1 hour a year, right? So this would raise it to 6, would be 3 hours each year for most professions except for nurses. And that was made in compromise with nurses, recognizing that nurses were oftentimes required to do so many hours each year for their facility. Additionally, you'll note, I think it's important to note that in Section 1, we do allow for the hours that the licensing board requires to be included as the hours that the hospital might provide, so that they can provide their certificate to the hospital and demonstrate that they have completed these hours already. For nursing, the hospital might still say that they would like them to take their own training so that they get that training, but it would be at the discretion of the hospital then to do so.
And then if I can follow up, and if this is in conformance with their CME requirements, if a medical board says that this diversity cultural training is certified as official CE, that would be credited to them. They wouldn't have to, for 30 hours every 2 years, I think, is what's mostly required. They could get credit for that as a part of that educational requirement.
Assemblywoman Torres, for the record, through the chair to Senator Stone, yes.
Thank you.
Senator Titus.
I think this one's mine. Thank you, Mr. Chair. And thank you for continuing to work on this bill and bringing it forward. I definitely support the education of all professionals to respect diversity and understand the different cultures. It's not just healthcare professions, but I think we need to be way more, not just, I tell my kids and family members, we can't just be tolerant of somebody else's background or beliefs or religion or choices. We have to appreciate them. So I definitely support training, but I wonder and I worry about this process of first, what my colleague, Senator Stone, brought up about the different hours, and can't quite see why one of them is 2 hours, the other's 4 hours, the other's 6 hours, because we're pretty much talking the same language regarding the importance of understanding the needs of others. And I'll use a personal example after you can respond perhaps why the different hours.
Assemblywoman Selena Torres, for the record, through the chair to Senator Titus, and I think that is a good question, right? And so originally this piece of legislation was meant to cover individuals working in, when we brought the 2021 version of the bill, it was meant to cover specifically mental health professionals, recognizing that cultural competency is critical. I believe cultural competency is critical to any practice and any trade and any profession, but even more critical when you're talking about mental health. And so when we brought the 2021 version, it specifically covered mental health professionals, and that's why we see that impact. Now, when we look specifically at like individuals under the Board of Medical Examiners, so specifically like physicians, physicians assistants that are overseen by them, their hours are already pretty like controlled on what it is that they're required to take, and so that's why we made those amendments over in the assembly, was to ensure that we were addressing that they already had like prescribed so many hours that were critical, whereas that's not true for other professions. I think the same thing really applies to nurses, right? Some nurses do work in mental health spaces, but not all nurses work in mental health spaces. And so in conversations with the Nurses Association, we had agreed at 4 hours, and I think that they might have a different position now, which is interesting, but it's what happens in the legislative process. We have the conversations, and then sometimes those decisions might change. But going to back to mental health professionals, I do believe that 6 hours is fair and makes sense for mental health professionals when that's core to their practice of treating patients.
So thank you for that, and can I continue, Mr. Chair? So again, and I'm an old doc, and I graduated from medical school in 1981, and I can tell you we had no training whatsoever. And we had training certainly in asking and doing a physical exam, asking questions, doing an exam on patients, but not at all that there might be different cultures and how we should approach that. And my personal example is I happen to practice in a rural area with but many Native Americans, and rapidly learned that I had to respect their privacy and ask questions a little different than I would have thought of. And one time I said, well, why didn't you tell me that before I did whatever? And they said, well, you didn't ask me that question. And so, I mean, I had to learn through practice all the appropriate respect and insight and some of the cultures that I wasn't trained. So again, I'm supportive of the training. However, I think that I know in Clark County, I'm not sure how many different communities you have of different cultural backgrounds. I'm sure many, 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 and if not, it's also in Clark County and in Reno too, you get visitors from literally all over this world. So I worry that having the training on cultural competency for regardless of what the health professional is, that perhaps, and I mentioned this during a hearing of my own bill about cultural competency, is that we need to maybe focus on the provider themselves and recognize their biases and how do you stay open and talk to anybody, because you can't control who you're going to see in the office. You can't control what their background is, what their choices are. So I worry about putting in statute mandatory training with specific topics when we don't know all the topics. And so I think a better mandate would be that we all, as providers, mental health and doctors and nurses, perhaps look at, and I don't see any of the suggestion in any of the things that they mandate that we do take, perhaps it's better to look at inward about our biases. I know I have biases, and I mentioned this to some of my friends and they just laugh, but as a provider, I had to get past my bias about fat people, because as a provider, I instantly, when I walked into a room and somebody was overweight, it was like an instant, I had to put on my face and be professional, but I had to work past that. That's not necessarily their fault that they're overweight. And so that was a personal bias that I had to work through in my career. So I worry that when we put into statute specific things that we have to address, we're missing so many more things. And so I think that the mandated hour at least of making sure that we understand our own biases in life is a better approach, and not specifically, okay, you have to do an hour and this and that. And that's just, I'll get off my soapbox. That's not really a question.
As some of the explanatories, nonetheless, I'll go ahead and reply to the comments, because I think that myself, and then I'll send it over to the experts joining us via Zoom today. I would like to address a couple things. So I do think our definition, specifically when we're looking at cultural competency as it pertains to the licensing boards, because there are kind of two separate parts of this piece of legislation. I mean, it is very general, and I think that it allows for practitioners to have autonomy and choice in what areas they're working on, right? Because I don't know a mental health professional in our state that's not going to work with people from various gender, racial, and ethnic backgrounds, or different religious backgrounds, or from the LGBTQ community, or children and senior citizens, or veterans, or people with mental illness, right? Or people with intellectual disabilities and developmental disabilities, or other populations that are that individual might better need to understand, right? So I think it's a very general definition that allows for that. I know that Dr. Leon Villa and Dr. Chapel-Love can probably speak more to that, as when we put this into practice, now it's already been implemented, and so they have already participated in some of those trainings that have kind of come from the need for more practitioners to be taking those trainings.
Dr. Leon Villa, did you want to start, or?
Sure. I think just to kind of go back to, and again, Dr. Sandra Leon Villa for the record, I wanted just to comment that and yes, we do have, all of us have implicit biases whether we are a person of color or not, but to place the responsibility on providers to obtain training or some type of way to help them see their own implicit biases is really difficult. I was a diversity chair for the Nevada Psychological Association for approximately 2 years, and sending out a survey to see who was even interested in cultural competency training was not surprising, and it may be surprising to you all, but people don't want to do these trainings, just like we don't want to do ethics trainings, but we are mandated to do them. And part of the trainings in cultural competency aren't just necessarily to learn about individual cultures, but if we're talking about implicit biases, and now we're talking about white supremacy culture and how these disparities are coming about. And if we talk about how predominantly white spaces like medicine or psychology or any other field really, disparities are happening because of implicit bias. And these trainings should include a component that helps, I guess, decolonize in a way and help understand how implicit biases are really a result of white supremacy culture. And so we're talking about something different. I don't think that we can absolutely rely on providers to sit with their own implicit biases unless they're actually doing trainings. I can speak for myself, but I think that Dr. Lauren Chappell-Love would agree when we talk about it's not exciting to do ethics trainings, but they're definitely necessary, and we are mandated to do them for a reason. So I think that yes, cultural competency is not something that is achievable because we can't ever be fully competent culturally. But it's definitely a journey that we need to continue on and continue learning about disparities. There's a reason why Black women are more likely to die giving birth. There's a reason why they're less likely to be believed when they're in pain. And then we're looking at historical context of why this is happening. So I definitely think it's imperative that we do mandate the training as part of legislation, just like we do with ethics and suicide training, because we can't rely on providers. As I've seen in psychology, they're just not willing to do it and sit with their own implicit biases.
Thank you so much.
Thank you.
Any other further questions? Vice Chair Nguyen, did you have a question?
I do have a question. It is in Section 1, subsection 5. It is the medical facility for the dependent and if you read down into that, it talks about how any such request must be approved or denied by the department not later than 10 business days after the receipt of the application. And I was wondering how you came up with that 10 days. Is that what was in the existing legislation, or what is the basis of that?
Thank you, Assemblywoman Torres, for the record, through the chair to Senator Nguyen. And what this actually was an interesting conversation. When I started working on this bill, I can tell you that maybe everybody was in opposition. I think we've gotten most people to a place where they're in a good spot. So it was definitely a lot of work on the part of myself and the stakeholders, and I appreciate their feedback. One of the main complaints was just the length of time that it takes in order for us to approve the training through the Department of Health and Human Services, and that they wanted more consistency with that. And so this piece of legislation seeks to do that. I did speak with DHHS about what would be a reasonable amount of time to approve those trainings. And so 2 weeks or 10 business days was what was settled on.
And then I guess my question is, as we had heard in a bill that was presented by Senator Titus about how people were applying for programs to be approved, and they were, like one organization was submitting their cultural competency program, and it was getting approved, and then another facility would take that same program and it was getting denied. And I know that there was some time period. So this 10-day period kind of came in combination with those kind of conversations.
Assemblywoman Selena Torres, for the record, through Senator Doñate to Senator Nguyen, this entire bill, I think, is meant to address some of those issues and some of those concerns that I heard from providers. But I think it also delayed the process and the implementation of the training within some of these facilities. And I think, there's specific language in here, and I would have to go through more specifically to find it. But there is language in here too requiring that there's clear outline of the requirements of that training, or what that training should look like within the Office of Minority Health and Equity. Too, they're required to post a list of qualifying cultural competency training courses. So I think some of those concerns are addressed, so that we're helping streamline training while also still continuing to ensure that our hospitals and facilities are providing culturally competent care.
And then just my final question, Chair, if that's fine. I do have a question about, just to clarify, I don't know if you've taken any of these courses that have been offered, and this might be for some of your co-presenters to be able to answer. It just kind of of piggybacks off of Senator Titus had kind of, talked about potentially having, I guess, requiring implicit bias training, to look at the provider and the perspective that they are coming at these things. Is as a part of any of this cultural competency training, is there any kind of component that also addresses kind of our own implicit biases that we have in, treating patients?
That's Ellen Torres for the record. So I'll see if Dr. Chapelov wants to go in or Dr. Leon. Yeah.
Dr. Lauren Chapel-Love, for the record. I can say that in practice, what this usually looks like, much less of, let me learn about a particular population, and much more about how can I institute knowledge relating to this population, coupled with my own biases, right, that negatively oftentimes impacts said population. How can I use that in the work? So I'm one of the things that my private practice does is diversity, equity, and inclusion consultation and training. And so I can say from one anecdotal piece, certainly not everyone that does training across the state, that you better believe we're talking about implicit bias. I won't, attempt to quote Maya Angelou here, but a situation of when we know better, we do better. And I think to Dr. Leon Villa's point from previous, it's very difficult to rely upon internal pressure to want to learn more about a particular thing, especially when people start to consider, DE&I related training, diversity, equity, and inclusion related training as, it's a checkbox I have to do. And so I can say from one perspective, absolutely, biases, addressing how my own history, how my own identities impact me and my ability to work with other people is oftentimes, if not always, included.
Thank you so much. And last question from Senator Stone.
Yeah, thank you again. If we're going to put something in statute, I think we had to try to make it as simplistic as possible. And going back to the question that my physician colleague and I both asked about why we see different hours for different things. As an example, for the nurse, 4 hours, and for the behavioral analyst, and I would think that becoming a behavioral analyst would have some type of cultural competency curriculum associated with it. To me, it seems like if we're going to have a course for cultural competency, diversity, inclusion, it would be one course, right? And so why would a nurse have 2 hours less of training than a behavioral analyst? I'm just trying to understand the difference in the hours. Is there training that a nurse gets that a behavioral analyst doesn't, and that why it necessitates 2 more extra hours?
As supplemental slated, sorry for the record, I'm happy to make it consistent for all professions and just put consistently at 6 hours. But I think it's important to note that each licensing board is separate. So the training that is appropriate for nurses is going to be different than the training that is appropriate for psychologists or the training appropriate for social workers, because it would be designed specifically to, the trainings are going to be specific to the profession that is providing those trainings, and then they're approved through that licensing board. So for example, if a group, and there are different, there's different groups around across the state that do provide culture competency training to like facilities and other areas. And so sometimes they have a training that has been approved by licensing board. They have to get approved by each individual licensing board. It was actually for that reason that we didn't allow for the training that hospitals provided to be approved for the licensing hours, is because they're different, right? Like we want it to be specific to that profession, because social work is going to be talking about different things and different practices than maybe a psychologist would.
So were these respective boards, did you consult with them and say what would be the appropriate number of hours of competency training that we should require, or did you or your colleagues make up what those hours should be?
A supplementary for the record. So this has been a bill that we've had many conversations about and invited many stakeholders into. I believe that the requirement for 4 hours for the nurses specifically was a request from the Nurses Association, and I did accept it. I understand that they might have a little bit of heartburn with it now, but that was originally a request, and that's kind of the number that we had originally settled on.
Okay, thank you.
All right, we'll go ahead and close question and answers, and we'll move on to testimony and support. If you are in support of this bill, please come forward. Once again, we are in support of AB 267. And just a reminder that we will start the clock at 2 minutes. Mr. Kelly, please begin.
Thank you. Good afternoon. My name is Patrick Kelly with the Nevada Hospital Association. We support the bill and are very appreciative of the Assemblywoman for bringing everybody together and listening to their concerns. I would like to address the nurse issue on the 2 hours, or 2 hours a year, 4 hours. That was one of our requests too, because you know, nurses have a lot of different requirements that they have to meet. And if we have an ICU nurse, they need to spend some time getting training on up-to-date techniques on ICU and the specialties. So we wanted to make sure that, you know, we address cultural competency, but we address competency in the core areas in which they practice also. So that was the reason. But we're very appreciative of this, and we've had problems getting the program up and going. We're ready to provide the training, and I think that the Assemblywoman's done a great job in moving us forward on this. Thank you.
Chair, members of the committee, my name is Cody Hoskins, Political Director for SEIU Local 1107. SEIU represents over 8,000 nurses and healthcare professionals in Nevada. We also are here in support of AB 267. We believe the cultural competency requirements being included here are going to be really important for our nurses, and we think that this is something we hope to have you all support. Thank you.
Good afternoon, Chair Donate and members of the Senate Health and Human Services Committee. Sheila Bray, University of Nevada, Reno, for the record. As a higher education entity in our state, we are supportive of continued education and training, especially in the areas that recognize the strength and the diversity of our state. Assembly Bill 267 provides an opportunity to ensure medical providers receive current training to best prepare them to serve their patients, our fellow Nevadans. Thank you, Assemblywoman Torres, for this bill. We urge your support.
Good afternoon, Chair and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record. Here in support of AB 267 for much the same reasons that we were in support of Senate Bill 365. We really appreciate that this bill clarifies those requirements for the facilities, and we appreciate Assemblywoman Torres for working so diligently with everybody in this process. Thank you.
Thank you so much. Anyone else in support of AB 267? Anyone in Las Vegas? And BPS, anyone virtually?
If you would like to testify in support of AB 267, please press star 9 to take your place in the queue.
Good afternoon, Chair and members of the Health and Human Services Committee. My name is Deanna Hewitt-Tran. That's DEANNAHUATRAN. And I'm the Coalition Coordinator for the Nevada Immigrant Coalition, here on behalf of the Coalition. The Nevada Immigrant Coalition consists of diverse organizations from across the state that work together to fight for immigration reform and immigrant justice. And we are here in support of AB 267. And I also wanted to thank Assemblywoman Torres for championing this bill. Cultural competency training is of utmost importance for medical facilities and should be not only an ethical duty, but professional responsibility for healthcare organizations, agencies, and providers that interact with our immigrant communities and other vulnerable communities in the state. Individuals come from unique cultures, backgrounds, and may have different beliefs and values that can influence their health behaviors and expectations of care. And cultural competency training helps healthcare providers and staff to understand and respect these differences that can lead to better communication and care that accurately reflects the cultural sensitivity that our community members deserve. Without such training, healthcare providers may unknowingly engage in cultural misunderstandings or perpetuate biases, leading to reduced patient satisfaction, poor health outcomes, and inequitable healthcare practices. We urge you to support, we urge the committee to support AB 267 as well, and thank you for your time.
Good afternoon, Chair Donate and members of the committee. My name is Steve Messenger. I'm with the Nevada Primary Care Association, representing the state's federally qualified health centers and operating Nevada Cultural Competency, a facility licensing program for cultural competency. I was going to bring you a bunch of data on health disparities, but you had such a great presentation that I won't go over those numbers, only to point out that federally qualified health centers have really been working on addressing the needs of underserved communities since their inception in the war on poverty in the 60s. And I've seen firsthand a lot of organizations that have done incredible work in these spaces and communities across the country. If you pay attention here, then we can see better outcomes. We know it. We've seen it happen, and we should see it in Nevada. So thank you to Assemblywoman Torres. Thank you to the committee. We support AB 267.
Thank you. Good afternoon. This is Connie McMullen, representing the Personal Care Association of Nevada. I visited and talked with the bill sponsor, and I told her that this is a compromise that we could live with. Having said that, I would like the committee to know that personal care agencies employ caregivers that are not licensed by profession. They do give annual hours of training, and we will include cultural competency in our training. We've been working towards that and have submitted training tests, which have not been approved yet, but we're looking forward to it. But we are unlicensed, and having said that, we would have rather have had the administrators and owners of the personal care agencies licensed to do this required training. But we do believe it, and we do support the compromise. Thank you.
Chair, there are no additional callers choosing to testify at this time.
Thank you so much. Let's move on to opposition. Anyone in opposition, please come forward. Seeing none, Carson City, anyone in Las Vegas, and BPS, anyone virtually.
If you would like to testify in opposition to AB 267, please press *9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And anyone in neutral, please come forward. In Carson City, anyone in Las Vegas, and BPS, anyone virtually.
If you would like to testify in neutral for AB 267, please press *9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. In the interest of time, I'll go ahead and close the hearing and thank our Assemblywoman for joining. We're going to move on to Assembly Bill 116. And we welcome Assemblywoman Brown May, so please begin when you're ready.
Thank you, Chair, members of the committee. Assemblywoman Brown May, proudly representing Assembly District 42 for the record. We're really excited to be here today. We know that we're on a time crunch, that we need to be back on the floor. But I wanted to make sure that we had an opportunity to walk through this bill pretty quickly. It is called the Down Syndrome Information Act, is how we're referring to it. It is specific to providing information about Down syndrome. And the best bills are the ones that come from our constituents, our friends, our colleagues, and that's why we're here today. So I'm going to introduce you to Jack Rovetti and his dynamic mom, Diana Rovetti, and they're going to talk us through where this bill came from and why we're here today.
Good afternoon, Chairman and committee members. My name is Diana Rovetti. I think everyone has a moment in their life when time stood still, a moment that you always will remember. I know I have that in my life, a moment when I can remember everything about the moment, and it should have been a joyous occasion. I should have been celebrating, but instead there were tears and I was scared. My moment was when my pediatrician told me that my baby boy, the one I've been dreaming of, I had 3 daughters, and then I was just so excited I'm gonna have this boy. But my pediatrician came to me and told me that my baby boy has Down syndrome. This happens approximately 50 times in Nevada every year, and I know if I would have known in 1998 what I know now, I would definitely have been celebrating. My son Jack this handsome young man sitting next to me has changed the course of my life, and has definitely changed it for the better. And I believe that he's also changed the course of my 4 daughters' lives for the better as well, making them more compassionate, more empathetic, and just all around very good humans. Many parents are given a grim outlook for their baby, and that is the reason for this bill. Families should be given hope and not fear and not be scared, but know the good things that can also happen in their life. And I would never give up this opportunity to have a son with Down syndrome for anything. It's enriched my life, and our whole family love Jack so much, and I believe he adds value to our community and to our state. Thank you.
Hello, you know me, Jackie Reddy. Yeah, my name's Jackie Reddy. I have great life. I graduated from Rainier High School from Patrick Pennant program at UNR. I have a lot of friends and I love my family. I have my own business. You know me, Jack's Popcorn Company. And right now, I'm volunteering at Piccolo School. In the summer, I was working at the Eddie in downtown Reno, far back. I think we should tell new moms I love having Down syndrome, and also, I'm happy in my life. I'm happy how I am. And also tell new moms that her baby is perfect. Yes, perfect.
You heard it here. New babies are perfect, even when they have Down syndrome. Down syndrome is not something to be frowned upon. And as we have an understanding of the real capabilities of all of our citizens with Down syndrome, we understand that they are our peers and our equals. Currently, 23 states have enacted Down syndrome information bills. Most recently, the bill was most recently passed in Idaho. It served as our primary example here for Assembly Bill 116. With that, we are happy to take questions or walk through the bill.
Thank you so much. Any questions from any committee members? Senator Stone.
Not a question, just what an inspiration, Jack, to have you here today. And love to try your popcorn, by the way. So to tell me how I can buy some of that. And to your mom for you guys even being here today and advocating that more information come out, and that we love our kids, even our kids that have special needs. I got a special needs granddaughter that I'm absolutely crazy about, and it brings out the empathy and love and compassion that human beings are certainly capable of having. So I'm just very happy that you're here, and I want to compliment the Assemblywoman for getting this information out to future moms and dads, brothers and sisters that are going to have a Down syndrome child or brother or sister, that it's not the end of the world. This is, we love these kids, and we want to show them that we love them. And I think by you having this information is going to really help a lot of these families out, and I really appreciate you bringing it forward.
Thank you so much. Senator Titus.
Thank you, and certainly appreciate the testimony. I have had some of your popcorn, and it is delicious, so thank you very much. Just a question and in concern regarding legislation about mandating what a provider does when they make a diagnosis. And so my concern stems from the fact when I diagnose somebody with congestive heart failure, there's not an NRS that tells me what I have to do after that. There's standard medical practice, and it changes actually as new medicines come out, new treatment comes out, that what you follow the gold standard or whatever's current for that particular diagnosis. And in my career, again, I mentioned earlier, and I'm old doc, the medications that I was using when I graduated from med school, from my Goodman and Gilman pharmacy book, book are not even practically in existence today. So when we legislate and put in statute some of these mandates, I worry about that. So singling out one process, one Down syndrome, although I'm supportive of the information, and I understand you did not apparently get information at the time and that their approach was a disappointment when it should have been joyous, I worry about us legislating medical diagnosis and making the diagnosis and then what we do and in statute. And so I do have concerns about that. Not that I'm not supportive of having a process of information, being thankful that you are here today, and every time you have presented for us, it's been it's better for all of us. And so you have added to all of us here, not only today, but in the past when I've seen you here. So saying that, I just have concerns about legislation, about what we as providers do once we make a diagnosis.
Thank you, Senator Assemblywoman Brown May, for the record. I appreciate your concerns through the chair to you in response to your question. We did walk that through in a number of different ways. The number of providers that would diagnose a baby with Down syndrome are very few and far. So it's not your typical medical doctor. You're not going to typically do that in your medical practice unless you are an obstetrician, a gynecologist, somebody who's going to do the actual diagnosis of a pregnancy. So those physicians, it's my understanding, already deliver multiple types of information. So this is saying that we need to prioritize the fact that a baby with Down syndrome is not in fact a tragedy and can indeed be a blessing, and that parents just need a referral source. So in an office, such as any medical office, it could be nothing more than a poster on a wall with a QR code for a family to get a referral source to go to. So we're not mandating the information that you're going to give, only that someone will be referred to. Nevada 211 was the example that was used on the assembly side. 211 has great referral sources, and we just want people who are receiving information about a diagnosis to be able to go somewhere to get up-to-date, current, accurate information that is peer-reviewed based on science, and not, I don't know what to do with you. I'm so sorry you're having a baby with Down syndrome, which is and has been the experience of many parents throughout our state. I hope that answers your question.
Any other questions? Let's move to testimony and support. So if you would like to testify in support, please come forward. And the bell should ring any point in time, so we're going to try to get as many folks as we can before it. Okay. Please begin.
Good afternoon, Chair and members of this committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities, and I'm actually going to allow Alyssa to go before me today. And I'm going to be helping her as well. Go ahead.
My name is Alyssa Marquez.
She wants me to repeat for her. My name is Alyssa Marquez.
I intern for Head Booties.
I am the intern at the Governor's Council on Developmental Disabilities. Who's next?
My service dog is Girl.
I have a service dog whose name is Girl.
I like bowling.
I like, you got that one.
I like football.
I like flag football.
If I manager 3.
She has testified at the legislature 3 times. This is a picture of
People.
I love people.
St. Gall Church.
And I love St. Gall's Church.
I'm really awesome.
She says I'm downright awesome. Wonderful. So I'll make mine super quick today. I want to talk to you guys about informed choice. Again, my name is Catherine Nielsen, for the record. Informed choice occurs when a person with or without reasonable accommodation understands all of the options available to them, including the benefits and the risks of their decisions. The process of informed choice doesn't have an end and doesn't occur just one time. Informed choice is part of an ongoing process of engaging people in person-centered conversations about their goals. And informed choice allows an individual with or without disabilities to be in control of their life's decisions and ensure they're making meaningful choices about what will impact their future. And this is where AB 116 comes in. When a person who is having a child that receives a diagnosis of Down syndrome, they should be afforded the right to make an informed decision about their own life and their children's future. As you've heard today, people with disabilities, and particularly those with Down syndrome, bring purpose to this world. As a constituent, I want to talk to you guys about something personal. Alyssa is my intern. While she is my first intern, she's also my favorite. When I enter the office in the morning, my light's on, the heater's going, and the office is open for business. That is all because of Alyssa. When someone comes into the office and is seeking information or resources, Alyssa greets them and finds out what they're needing so that she can alert the appropriate staff member. We sent hundreds of health information binders across the state of Nevada to help ensure the public is prepared for their next emergency. Alyssa was the staff member primarily responsible for assembling and shipping these. Alyssa is valuable as a staff member. However, she brings me joy as a person. She makes my life better. She makes me excited to enter the office in the morning and sad to leave at the end of the day. While I'm the executive director, and I'd like to point out the importance of providing the opportunities for families to make an informed choice, I, as a constituent, want you to know that people with Down syndrome are valuable. They bring so much more value to society, and that has allowed people to believe that they bring no value for far too long. AB 116 would ensure their value is finally upheld in Nevada statute. Thank you.
Good afternoon, Senators. My name is Ellen Marquez. I'm the Self-Advocacy Coordinator for the Governor's Council on Developmental Disabilities. But today I am here as a proud parent of a young adult with Down syndrome. Over 20 years ago, I had an amniocentesis and was told my daughter would be born with Down syndrome. There was no explanation, no information, just go ahead and read some books and learn about it and see what her future will look like. Those books were outdated, mostly explained all medical issues she could be born with and institutionalization. As disheartening as this was, I looked forward to the day I would meet my precious girl. My daughter was born on March 10th, 2003. The doctor confirmed she had Down syndrome, but otherwise appeared healthy. Later that day, the hospital social worker came in with no compassion. Is she going home with you? My thought was, where else is she going? Is somebody coming to take her from me? She gave very little information and resource to contact. AB 116 will give parents who get a diagnosis of Down syndrome the information and support services to understand Down syndrome is not the end of their child's life, but the beginning of a new and different adventure. Even though it may be challenging at times, my daughter had open heart surgery at 2.5 months old. They are now part of a diverse and supportive community. Our children go to school with their peers, learning alongside their friends, and can graduate with the alternative diploma, the parallel curriculum to the standard. They can be employed, attend college, and are the future of our communities. Parents need to be aware when they receive the diagnosis of Down syndrome, there is so much more. Knowing others with Down syndrome, like Jack Rivetti, entrepreneur and ladies' man. Kaylin Kelderman, prep cook and living independently. Kenley Castleman, spunky elementary school student who knows no stranger. And Alyssa Marquez, DD Council intern and special cameo beauty pageant queen for 2022, provide encouragement for what can be. Thank you.
Good afternoon, Ms. Chair and members of the committee. My name is Mary Bryant. Excuse me. I live in Reno and have a beautiful 28-year-old daughter with Down syndrome who's not here today because she's working. When Kaylin was born in 1994, her having Down syndrome was a surprise to us. I had recently had a miscarriage, so didn't want to take the chance of having an amnio. She was born 2 weeks late, the longest 2 weeks of my life. I was fortunate to have a doctor who was sensitive and knowledgeable about Down syndrome. About 2 minutes after she was born, he came to my husband, Bill, and I and said, I strongly suspect your daughter has Down syndrome. And he said it without acting like it was a death sentence. He was just very matter-of-fact about it. Dr. Farringer went on to say there were resources that could help Kaylin to reach her potential. He told me that he had other patients who had children with Down syndromes and that their families got back to normal after the shock. He mentioned, He mentioned one snow skiing family, and I thought, oh, how sad not to be able to ski anymore. He went on to tell me that the little boy started skiing as soon as he was walking. The social worker came in shortly after and gave us contact for Nevada Early Intervention Services and the family organization associated with it. We were able to start KK in early intervention right away and meet some of the other parents who are now some of my best friends. This might not sound like a life-changing interaction between the doctor and the social worker and us, but it was what we needed not to be completely devastated. It was still an adjustment, and it's actually been a lifetime of adjustments. Every new age and situation can be challenging. When I compare this to other friends who've gotten the diagnosis like it was a death sentence or worse, I feel really fortunate. Families are getting the diagnosis with inaccurate and disturbing information, especially if they get a prenatal diagnosis. I want to mention that I'm very pro-choice and believe women should have complete autonomy in their decisions about their body and their health care, including abortion. But women need to have accurate information in order to make these informed choices. Kaylin is now 28. She lives in her own apartment at Innova Apartments and works at Five Below in the Summit Mall, where she was recently Employee of the Month. She graduated from the Path to Independence program at UNR, which is an inclusive 2-year program for students with intellectual disabilities. Her life has not been without challenges.
Thank you so much, ma'am. If you can wrap up your comments,
Okay,
please.
oh, I'm sorry. She was, it also changed our whole family. My husband and I ended up working for nonprofits. I started the Path to Independence program, and our daughter got an MSW and is now going to be working with people with disabilities. But the challenges presented by Kaylin having Down syndrome are minor compared to the good she's done. And one more thing, there are no guarantees with any of our children. When a normal child is born, no one says, ooh, he could be a mass shooter, he could get leukemia, he could this, he could do that. So why do we single out people with Down syndrome to talk about how horrible life is going to be? So I want women to have the facts so that they can make informed choices. Thank you.
Thank you, Mr. Chair and members of the committee. For the record, my name is Mary Przinski, here representing SNAP, the State of Nevada Association of Providers. SNAP is an umbrella organization, and the members of the organization provide services for intellectually challenged or disabled. Many of the folks who are helped with our members are diagnosed with Down syndrome, so we're very supportive of all educational materials that may be offered to their families who are looking for community and medical supports. Thank you.
Thank you so much. Seeing no one in Carson City, we'll go to Las Vegas, to the folks down there.
Thank you, Mr. Chair, members of the committee. My name is Lisa Holmquist, Holmquist, and I am the founder and CEO of Down Syndrome Connections Las Vegas. I am here with the star of our show today, Miss Hannah Hughes, who is going to have a video for you. But I will say that Down Syndrome Connections provides trained parent mentors for people who have a new birth or prenatal diagnosis to connect them to our community and help them answer questions, because we've been there, done that. So I'm going to turn it over to Hannah and let her say a few words, and then we're going to show you a cute video.
Due to the interest of time, we might have to skip the video if that's okay. But if there's other folks that would like to testify and support in Las Vegas, now would be the time.
Say a few words, or you want me to show the video?
I want video.
She said, sorry, Lisa Holmquist again. She said she would prefer you show the video, so I'm going to do that real quick if that's okay with the chairman.
I'm Hannah, and I'm 19. My life is good. I am awesome. I am brave, and I can do things. I can read. I watch Netflix every day. I love my dad. My dad is kind of annoying.
He is awesome. If you were going to meet a new family that never knew anybody with Down syndrome before, and they had a new baby, what would you tell them?
Just be happy and also baby is beautiful. They can do their thing. They can walk, they can read, they can talk. Be happy with them.
Thank you very much.
Thank you so much.
Time
And
for one. Time for one more, real quick.
you're the last one. If you can please wrap your
All right.
comments quick, please.
No, thank you. Good afternoon. My name is Connor Slife. I'm a father of 3 children, and my youngest, Annalise, is 2, has Down syndrome. And I just wanted to say that when my wife and I first received word that she had Down syndrome, we were devastated, and all sorts of images ran through our mind of short life expectancy, mental disability, physical limitations, sort of a future of suffering for her and our family. But what we've discovered is that most of that is not true, and there are amazing benefits. I'll just make it really quick. My daughter Annalise is the light of our family. She is the light of our extended family. She is the light anywhere we go, restaurants, any establishment. She is an amazing little girl. And I cannot imagine the world without her. And I wish when I received this diagnosis, I had someone like me to talk to that could explain exactly what Down syndrome is and all the wonderful benefits. And so I just wanted to fully support this bill, and I thank you very much for your last-minute time.
Thank you so much, sir. At this time, we'll go ahead and move on to opposition testimony. Is there anyone in opposition of this bill? Please come forward. Anyone in Las Vegas? And BPS, anyone virtually in opposition?
If you would like to testify in opposition to AB 116, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And anyone willing to testify in neutral on this bill, please come forward. Seeing none in Carson City or Las Vegas, BPS, anyone virtually?
If you would like to testify in neutral for AB 116, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. I'll go ahead and close this hearing. In the interest of time, we will reschedule AB 100 to Thursday's committee agenda, and we will now call for public comment. So anyone in Carson City or Las Vegas, and anyone virtually.
If you would like to provide public comment, please press star 9 to take your place in the queue. Chair, the lines are open and working, but there are no callers for public comment at this time.
Thank you so much. That concludes our meeting, and we'll see everyone on Thursday. Meeting's adjourned.